All right, let's do something a little different today. We're going to simulate a high-stakes consultant surgery exam, the viva. I'm going to play both parts, the tough examiner and the on-the-ball candidate, walking you through a classic case of a pancreatic mass. So let's just dive right in. Right, you're in the hot seat. The clock is ticking. As the examiner, I'm starting you off with a really broad question. This is all about seeing how you structure your thinking under pressure. It's not just about the facts you know, it's about your process. Let's see how our candidate handles it. And of course, the candidate knows exactly where to start. You never, ever jump to conclusions. You have to start with the fundamentals. Okay, switching hats now, I'm the candidate. Here's how I'd answer. Thank you. I begin with a thorough history and a comprehensive physical exam. So the key things that stand out are that we have a 49-year-old man, he's had this progressive upper abdominal pain for about 2 months, and he's feeling full early. What's also important is what he doesn't have. No jaundice, no weight loss. Then, on the exam, the big finding is this palpable 6 by 6 centimeter mass in his epigastrium. It's smooth, and critically, it's not tender, and it's not pulsatile. Back to the examiner. Okay, that was a really clear, concise summary. So the next logical step is to see if you can put those pieces together. What's on your list of possibilities? As the candidate, my thought process is this. Well, based on where the mass is and how it feels, my number one thought has to be a pancreatic mass. But you can't stop there. I'd also consider a pancreatic pseudocyst, maybe a gastric mass that would explain the early satiety. And, you always have to think about an abdominal aortic aneurysm, though it's less likely since it wasn't pulsatile. Excellent. That's a really well-reasoned differential list. Now the examiner wants to know how you're going to figure out which one it is. So let's move into the diagnostic workup. So the examiner asks for the plan. This is a big test. Are you being logical? Are you being cost-effective? And look, most importantly, is your plan safe for the patient? All right, candidate's response. I'd start with some baseline blood work and then move on to imaging. And whoa, these results, they're really telling a story. Look at the bilirubin. Both total and direct are way up. That tells us there's some kind of biliary obstruction. The blood glucose is also sky high, which you can definitely see with pancreatic problems. But the real kicker? It's the tumor marker, CA19-9. It's at 878. That is massively elevated and points very, very strongly toward a pancreatic cancer. So my very next step is a CT of the abdomen, and I'd be sure to order the specific pancreatic protocol. The findings here are absolutely key. We're seeing a cystic lesion right in the body of the pancreas. And look at this. The main pancreatic duct behind it is dilated to more than a centimeter. That's a really significant finding. But to really clinch this diagnosis and get a tissue sample, I'm going to want an endoscopic ultrasound, or EUS, with a fine needle aspiration. The EUS confirms everything we saw on the CT, but it's the fluid analysis from that cyst that's the final piece of the puzzle. It comes back positive for mucin, and it's got high levels of amylase and CEA. That combination is practically pathognomonic for a specific type of pancreatic cyst. So putting all of that together, the history, the exam, the labs, the imaging, the fluid, my definitive diagnosis is a main duct type intraductal papillary mucinous neoplasm, or IPMN. That is a confident, correct diagnosis. The candidate has just walked through that workup perfectly. But, getting the diagnosis is only half the battle. Now comes the really critical part, planning the management. The examiner is happy with the diagnosis, so the focus now shifts completely to treatment. This is where you really show your surgical judgment and your commitment to patient safety. Okay, as a candidate, I'd lay out a really systematic pre-op plan. The management here is going to be surgical. I'd plan for a distal pancreatectomy with splenectomy. My preoperative prep would be meticulous. Absolutely crucial is vaccinating the patient against encapsulated bacteria at least 2 weeks before we take out the spleen. Then I'd admit the patient, keep them NPO, start IV fluids, and make sure they have all the necessary prophylaxis for blood clots, infection, and stress ulcers. And of course, a full anesthesia consult and getting informed consent are mandatory. A very safe, very thorough plan. But a good Viva exam will always test how you handle things when they don't go according to plan. This is really where they separate the good candidates from the truly great ones. So the examiner throws the first curveball, a classic post-op problem. They want to see if you can recognize the pattern immediately and know the specific diagnostic test. The candidate has to be quick and confident here. This presentation screams postoperative pancreatic fistula.
To confirm it, I'd immediately send a sample of the dream fluid to the lab for an amylase level. If that fluid amylase comes back more than 3 times the serum amylase level, that confirms a diagnosis.
And here comes another curveball, this time from the pathology department. This is testing your knowledge of surgical oncology and long-term surveillance. A positive margin is a big deal. A positive surgical margin is a really significant finding. It means the risk of this coming back is much higher. So this patient is going to need vigilant, long-term surveillance. My plan would be to get an MRCP, that's a special MRI for the ducts, every 6 months, and we'd likely continue that indefinitely. Now, the examiner is rewinding the whole case. This is a test of a critical decision point. This is about knowing when not to operate, which is honestly just as important as knowing how to operate. The candidate's answer here needs to be definitive. Oh, enlarged para-aortic nodes on the initial CT scan. Well, that would suggest metastatic disease. That is an absolute contraindication for a curative surgical resection. In that case, the entire goal of management would shift from curative to palliative, and we'd focus on symptom control and quality of life. And that's a pass. The candidate has shown a structured approach, sound clinical judgment, and the ability to handle whatever was thrown at them. So let's step out of the role play for a second and just summarize the key strategies that lead to success here. So, what did we just see? First, the candidate always started with the basics. Every single answer was structured logically, from the differential to the management plan. They showed a safe, systematic approach at every single turn. They anticipated common problems like that pancreatic fistula and knew exactly what to do. And crucially, they knew the red flags. They knew when not to operate. And they did it all while staying calm and thinking clearly. We've covered a ton of ground here, from the first symptom all the way to long-term follow-up. But in a complex case like this, with a less than perfect outcome, like a positive margin, what's really the most important thing for that patient's future? It's not just about how often you do a scan. It's really about a multidisciplinary approach with close monitoring, good patient education, and a real focus on their quality of life. That, right there, is the key to successful long-term management.